In this video, we will be discussing facial palsy. Before we begin, consider the following questions. What are the normal functions of the facial nerve and its branches? What are the major causes of facial palsy? What are the key points of taking a history and examining a patient with facial palsy? What is Bell's palsy and what is the treatment? The facial nerve, cranial nerve 7, is primarily responsible for controlling the muscles of facial expression. In addition, it innervates the stapedius muscle in the middle ear, the stylohyoid, and the posterior belly of the digastric. It also carries taste sensations from the anterior two-thirds of the tongue and provides parasympathetic fibers to the lacrimal and salivary glands, excluding the parotid, which is innervated by the glossopharyngeal nerve. After exiting the skull through the stylomastoid foramen, the facial nerve enters the parotid gland and divides into 5 main branches: the temporal, zygomatic, buccal, marginal mandibular, and cervical, each responsible for innervating different muscles of facial expression. Facial palsy refers to weakness or paralysis of the muscles of facial expression, usually on one side of the face, due to dysfunction of the facial nerve. Depending on whether the lesion is central or peripheral, it can affect the upper face, the lower face, and sometimes both. Peripheral facial palsy involves the facial nerve after it exits the brainstem, for example, Bell's palsy, the most common cause. Central facial palsy is caused by damage to the brain, for example in stroke, and affects only the lower part of the face on one side. Peripheral causes of facial palsy include infections, such as herpes simplex, herpes zoster, causing Ramsay-Hunt syndrome, Lyme disease, and otitis media. Trauma, including temporal bone fracture and surgical injury. Tumours, such as acoustic neuroma or vestibular schwannoma, and parotid gland tumours. Neurological conditions such as Guillain-Barré syndrome and sarcoidosis, causing Hereford syndrome. Finally, we have Bell's palsy, which is idiopathic inflammation or swelling of the facial nerve and is the most common cause of peripheral facial nerve palsy. Central causes include stroke, brain tumours, multiple sclerosis, and traumatic brain injury.
A thorough history should be obtained, considering the onset and progression of the facial palsy. Inquire about potential precipitating factors such as recent viral illnesses, autoimmune conditions, or infections. Associated symptoms can offer important diagnostic clues. For example, ear pain, hearing loss, or otorrhea may suggest a middle ear infection as the underlying cause. Conversely, a slowly progressive palsy in the presence of a facial mass raises concern for a salivary gland tumor. The history should also assess functional impact. For instance, eye symptoms such as dryness or a gritty sensation may indicate incomplete eyelid closure or involvement of the greater petrosal nerve. Hyperacusis may point to dysfunction of the nerve to stapedius. Otoscopy should be performed to identify possible otological causes. A painful vesicular rash in or around the ear is characteristic of Ramsay-Hunt syndrome, often mistaken for Bell's palsy. A bulging, erythematous, tympanic membrane may indicate acute otitis media. A full cranial nerve examination is essential to confirm the facial palsy and to assess for involvement of other cranial nerves. It also helps to distinguish upper motor neuron lesions, which typically spare the forehead, from lower motor neuron lesions, where all branches are affected. Finally, inspection of the external auditory canal may reveal reduced sensation in cases of posterior auricular nerve involvement. Grading systems are useful to quantify the severity of the facial palsy and monitor recovery. The most commonly used grading system is the House-Brackmann, divided into grades 1 to 6. Grade 1 is normal, while grade 6 indicates no detectable facial motion. The most important differentiation to make is between grade 3 and 4, where the inability to close one's eye completely would indicate a grade 4 palsy. The drawbacks of using this grading system stems from the subjective interpretations of slight compared to severe facial weakness, differentiating the various grades, which may incur poor inter-observer reliability. However, it provides a useful global score that can quickly and concisely convey the severity of the facial palsy. Another grading system used is the Sunnybrook Grading system, where the evaluation of the extent of palsy is split into 3 sections: resting symmetry, symmetry of voluntary movement, and synkinesis, involuntary movement. Specific signs are recorded with individual scores, for example, the presence of a symmetrical open mouth smile or any involuntary gentle eye closure. This allows a more objective and thorough assessment to be carried out, highlighting different facial regions. The grading system is summarized in an easy-use format on entcalculator.com/Sunnybrook Grading System.
Bell's palsy is the commonest cause of facial nerve palsy. It likely results from the unique anatomy of the facial nerve in its intratemporal course, where it is confined within the rigid bony fallopian canal. The labyrinthine segment is the narrowest part of this canal. Inflammation and swelling of the nerve in this confined space cannot expand outward, so the nerve is compressed against the rigid walls. This raises intraneural pressure, compromises the vasa nervorum, and results in ischemia and paresis. As a diagnosis of exclusion, various upper and lower motor neuron causes have to be considered and excluded before Bell's can be confirmed. To reduce swelling of the cranial nerve, Bell's was treated with prednisolone, 1 mg per kilogram, up to 60 mg, with a protein pump inhibitor cover. Using ophthalmic lubrication and an eye patch when sleeping will also help protect the eyes. Importantly, if there is evidence of keratitis, a referral to ophthalmology is needed.
Prognosis. Generally, the outlook is good, with around 80% of individuals recovering spontaneously without any major intervention. Several factors influence prognosis. Those with incomplete paralysis tend to have a better outcome than those with complete paralysis. Bell's palsy also has a better prognosis than Rumsey-Hunt syndrome, which often involves more severe nerve inflammation. Recovery usually involves 3 stages, with the duration in each stage varying between individuals. Flaccid paralysis is the initial stage where the face is loose, floppy, and more asymmetrical due to a loss of tone in facial muscles. Other symptoms can include difficulty speaking, eating, and drinking, and dry eyes if the muscles around the eyes are affected. In the second stage, paresis, there's improved facial symmetry and muscles feel firmer. This is when facial physiotherapy can begin. Thirdly, synkinesis is the development of involuntary unintended facial movements that occur with voluntary ones. For example, the eye may close when smiling. This usually occurs around 4 months into recovery, often around the cheeks and eyes, and is due to misdirected nerve regrowth. If there's no improvement, further evaluation is important. This usually involves an MRI and/or other lab tests, including an autoimmune screen to check for any underlying conditions. Facial function plays a crucial role in communication and emotional expression. Therefore, facial nerve palsy can significantly affect psychological well-being, so mental health support is important. Facial physiotherapy helps to restore movement by improving flexibility and mobility of facial muscles through gentle stretching. In some cases, Botox can be used to reduce synkinesis and improve facial symmetry.
Hope you enjoyed this video. Please consider subscribing and let us know what you'd like us to cover next.